Dr. Omkaro, working as a medical advisor at Hetero Healthcare. Our topic of discussion for today is experience sharing program on managing postpartum hemorrhage. The purpose of today's meeting is to have a better understanding of the postpartum hemorrhage and role of carbetocin in it. Before commencing, I would like to introduce Hetero as an organization to you all. Hetero is serving in the healthcare industry since more than 25 years. It has more than 300 products in its portfolio. It has 21,000 employees globally and is also among the largest manufacturers of ARV, API, and FDF in the world. It also has 36 state-of-the-art manufacturing facilities and has its presence in more than 126 countries. It also has Asia's largest API manufacturing facility at Visakhapatnam in Andhra Pradesh. The aims of Hetero include striving to fulfill unmet healthcare needs and reaching to customers across India. It also has wide product range encompassing multiple specialties. Hetero has a distinction of bringing 4 biosimilar products to market within 5 years of initiation. During the COVID-19 pandemic era, Hetero was pioneer in antiviral and offered oseltamivir, favipiravir, and remdesivir in its respective dosage forms. Now, I would like to introduce our speaker for today's meeting, that is Dr. Neelam ma'am. Ma'am is currently working as a consultant obstetrician and gynecologist at State Hospital in Valsad. She has been former consultant at VBCH Hospital in Silvassa. Ma'am has done more than 5,000 normal deliveries and more than 2,000 independent cesarean sections. She has special expertise in high-risk obstetrics, including placenta, accreta, and complicated pregnancies. So, with this, I welcome you, ma'am, and hand over the session to you.
Thank you. So, shall I start?
Yes, ma'am.
So, what is postpartum hemorrhage? Postpartum hemorrhage is the blood loss of more than 500 ml following a vaginal delivery and more than 1,000 ml following a C-section. But even if the blood loss is less, then also we will label the patient is having postpartum hemorrhage if the patient becomes vitally unstable. That is, if the patient has hypotension or reflex tachycardia, then also we can label it as PPH. And PPH is very common. And especially in the developing countries and low resource countries, it is very common, and it is the most common cause, one of the common cause of maternal mortality, and in low income as well as in high income countries. So, maternal mortality, postpartum hemorrhage is the leading cause of maternal mortality, and it is accounting for around 35% of the maternal deaths. And PPH incidence in India, coming on to that, 38% of the maternal deaths are due to PPH, and 25% of the global deaths take place in India, which are because of PPH. And 2/3 of this attribute to PPH. India has an unexpectedly high maternal death rate, and especially because in the rural area where the pregnancies are unbooked, unregistered, patients don't want to go to a private hospital or a government bigger hospital to get delivered, or they late referrals because patient already is anemic, and because of the social stigma. So PPH is very common. Can you change the screen for me? So now coming on to the etiology of PPH. So we already know tone, trauma, tissue, and thrombin. So tone, most common cause is uterine atony. That is inability of the uterus to contract, which may lead to continuous bleeding. Then thrombin, coagulopathy, especially in patients of abruption, if the patient is going into DIC, or if the patient is having some liver disorder, where there is some coagulopathy, or there is some antiphospholipid antibody syndrome or anything, which can lead to PPH. Trauma, which is very common, especially when the cervical tears, which are unvisualized, not repaired at timely basis, then also it can be a problem. Or there is a major laceration, or there is a very deep episiotomy that can also lead to trauma, especially if there is extension of incision in cesarean section, when the incision is going into the broad ligament, or if it has gone deep down where it then also it can lead to postpartum hemorrhage, and tissue that is retained placenta or abnormal placentations like placenta creta, placenta percreta, that can also lead to PPH. Next slide, please. Can you change the slide for me? So now coming on to the clinical findings of PPH, what are the clinical symptoms and signs? There will be hypotension, there will be tachycardia. If it is atonic, then there will be loss of uterine contractions. If the uterus is ruptured, then there will be an abnormal counter of the abdomen and generalized tenderness you can feel, and circulatory collapse, that is hypotension, tachycardia, and collapse of the patient, or increased abdominal girth depending upon. And if the patient is having cervical tear, or if there is a big vaginal laceration, then the patient can profusely bleed. So now coming on to the clinical findings, now we are labeling the degree of shock according to the levels of blood loss. So 10 to 15% of what the body of the blood loss, then it is compensated. Now we come to mild, moderate, and severe, which is based divided on the basis of percentage. That is 15 to 25%, 25 to 35%, and 35 to 45%. Now, the more important is the blood pressure changes. That will only help us to label the patient, whether the patient is in hemorrhagic shock, how much resuscitation, how much fluid the patient requires. So basically, that also can be divided into mild, moderate, and severe. So if there is slight fall, and if there is marked fall, and there is profound fall, then we can label it as mild, moderate, severe. And based on the signs, that is weakness, tachycardia, restlessness, pallor. And once the PPH happens, once there is ample amount of blood loss, the first organ which will be affected is kidney. There will be oliguria, there will be decreased urine output, and then there will be collapse, or there can be HIE, and then air hunger and anuria. Finally, when the kidney stops functioning, that is the late stage of PPH. Next slide, please. So now approach towards the PPH. First, we need to know what is the cause of PPH. If the uterus ka tone, if the uterine atony is there, then we have to do proper active management of third stage of labor, and then we can palpate the uterus and massage the uterus, and then we can give uterotonic drugs. And now coming on to, if there is a trauma, if there is a tear, if there is any placenta creta, then we have to operate accordingly. So or anything, then you have to repair the tear, especially the cervical lacerations. If there is a deep episiotomy, if the episiotomy is reaching up to the fornix, then we have to repair it properly. Similarly, if the cesarean section scar has extended deep down, or if it is extended into the broad ligament, then we have to
Hello, ma'am. Yeah, ma'am, your voice is breaking a bit. Hello, ma'am.
and we have to do sorry, can you see me? I cannot see you, sorry.
Yeah, yes, ma'am. Now you're audible. You're visible as well, yes.
Okay. So basically, if it is accreta, percreta, then we can do a pre-op uterine artery embolization already when it is diagnosed on MRI or either on ultrasound, and then we can go for cesarean section so that we don't land up in PPH. Similarly, if the placenta is retained, then we need to first find out the cause why the placenta is retained. When it is accreta or percreta, and if we don't know, then it will be catastrophic to remove the placenta because it might bleed heavily. And And if the patient is having some liver disorder, or if the patient is already in DIC, then we need to arrange the blood products and everything in hand, and then we need to operate. And liver function test, especially AFLP, acute fatty liver of pregnancy, where the mortality rate is very high, where the chances of PPH are very high. If the patient has encountered hepatitis E in pregnancy, then also the prognosis is very poor. So depending upon the case to case, we need to approach the patient. But basically, the first approach is that we have to first find out the cause of the PPH, and then we have to accordingly.
Hello, ma'am. Your voice is breaking a bit, ma'am.
Sir, I think man is having network issue.
Yeah, Balaji, is my voice audible to you?
Ma'am, I think you are having network issue. Your mobile.
Whether I am audible or not.
Yeah, you're audible now, ma'am. Yes. There was bit glitch. Your voice was not audible a bit. It was breaking. Now it is audible.
Yeah.
It might be because of network issue, ma'am.
Yeah. Are you able to see me?
Yes, you are visible, ma'am. Just the screen is
Yeah.
tilted. It is in vertical mode currently.
Yeah. Fine.
Yeah, yes.
Oh, it is fine now.
So can you change the slide for me?
Yes, ma'am. Sure, yes.
So now we will come to carbetocin. So basically, everyone knows that we are using oxytocin for management of third stage of labor. But there are some problems with oxytocin. Oxytocin is first we need to properly refrigerate. When we have to store it at 2 to 8 degrees Celsius, and it is very important because in rural India, the fridges are not working, there are light cutouts, and it is very difficult to store oxytocin. And if it is not maintained at an ideal temperature, it will not work. We need to then change the vial. So that advantage carbetocin is having because it is stable at room temperature, and it also has a shelf life of about 24 months at 30 degree and 75% humidity. So in countries like India, where the temperature is very high, where already where humidity is on a higher side, so carbetocin is comparatively more stable, and especially for rural India it is the best. And because it does not require any cold chain storage, so obviously the logistic cost will also decrease, and it is provided in a vial. So it is best for resource poor countries. Can you change the slide for me? So now, when to use any uterotonic agent, either oxytocin, carbetocin, or permethrin, misoprostol, where after at the crowning of baby's head, at the delivery of anterior shoulder, at the end of second stage of labor, and following the delivery of the placenta. So mostly what we are using is active management of third stage of labor, where we prophylactically use so that we don't land up in PPH. Prophylactic drug use and active management of third stage of labor, in which there is controlled contraction to remove the placenta, and there is uterine massage as well. And therapeutic use, that is which we use for management, for the actual when the PPH is already encountered, and then we are using for management of PPH. And the molecules which are, we already know, oxytocin, carbetocin, and everything. Can you change the slide for me? So carbetocin, what is it? It is the next generation drug. It is a drug which is long acting, and it is an analog of oxytocin, and it has therapeutic indication, that is it is mainly used for prevention of PPH due to uterine atony. And the most common cause amongst the causes of PPH is atonic uterus. And one vial contains around 100 microgram of carbetocin in 1 ml solution. for injection. And carbetocin, yeah. Carbetocin was created by, there were some modifications which were made so that it becomes a more heat stable molecule, and we have prolonged the half life so that it acts for a longer time. So we don't have to re-administer it. Next slide, please. Next slide. So in the champion trial, carbetocin was proved non-inferior to oxytocin in management of PPH. And carbetocin decreases the need for other uterotonic agents. That is definitely there, because the uterine tone, what I have personally experienced, that uterine tone comes within minutes. And secondly, we don't have to use everything else. कि ऑक्सीटोसिन भी यूज किया, फिर मिथर्जिन भी यूज कर लिया, फिर उसके बाद हमने मीजोप्रोस्टॉल भी यूज किया, फिर कार्बोप्रॉस भी यूज किया. तो वंस यू यूज कार्बोटोसिन यू डोंट नीड एनी अदर ड्रग. मतलब इतना ज्यादा बहुत सारी चीजें देने की जरूरत नहीं पड़ती, व्हाट आई हैव रियलाइज्ड. एंड सिंगल डोज कार्बोटोसिन इज इनफ. Oxytocin, what we give is like we have to first we give 10 units IM, then we have to give an infusion that is 20 units in around 1 unit of NS over 4 hours, and again an infusion of 4 hours. So that advantage carbetocin has, that we can give a single dose. And almost the blood loss is also less, what I have experienced. And efficacy and safety of carbetocin versus misoprostol, matlab we have to always, when you use oxytocin, we have to use something else. But when you use carbetocin, what I have realized, especially in low risk patients, that only a single dose of carbetocin is enough. Can you please change the slide for me? So now how does oxytocin act? Oxytocin, it will bind to the oxytocin receptors which are present in the uterine myometrium, and it will stimulate contraction of the uterine smooth muscle by increasing the sodium permeability. Now carbetocin, which is heat stable, it will bind to the oxygen receptors in the uterine smooth muscle, resulting in rhythmic contractions and increase the frequency of existing contractions and increase uterine tone. So it is what oxytocin is there. When we give it IV, it is almost, it will immediately act, and with peak concentration reaching after 30 minutes. And half-life is around 1 to 6 minutes. When we use IM oxytocin, then the onset of action is slightly slower. That is, it will take around 3 to 7 minutes, but produces a longer effect, that is around 60 minutes. But when we compare it to carbetocin, the effect will last for about 60 minutes if we use IV. And IM, for there will be rhythmic contractions for around 120 minutes, and the half-life of carbetocin is more, that is around 40 minutes. Now storage and transport, we, as we already know, the storage conditions, we can we can store up to 30 degrees Celsius. So cold chain maintenance and that slightly reduces, and it is comparatively heat stable, and it is mainly used in prevention of PPH. Can you change the slide for me? Next slide, please. So it was what is champion trial? It is a carbetocin hemorrhage prevention, and it compared carbetocin and oxytocin. So no, the double blind. It was a double-blinded randomized trial, and it was to compare the effectiveness and safety of heat-stable carbetocin to oxytocin in the prevention of PPH after vaginal birth. And around 30,000 patients were enrolled. And the primary outcome was the proportion of women with blood loss of at least 500 ml or the use of additional utero comparing the main primary outcome of that. Hello?
Yes, you're audible, ma'am.
Yeah.
Just your screen is tilted.
Yeah. Can you wait, please?
Yes, okay, ma'am. Yes.
Yeah, it's fine.
Yes, it's fine now. Yes.
Yeah. So the primary outcome we are comparing is the proportion of women with blood loss of at least 500 ml, or the use of whether have to use any additional uterotonic agent, and the proportion of women with blood loss of at least 1 liters. Next slide, please. Next slide. Can you change the slide for me?
Yeah, ma'am, I have changed. Is it visible to you?
Yeah, it's fine.
Yes.
So now, coming on to the efficacy was almost same. Okay, and the blood loss, it is carbetocin was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml or the use of additional uterotonic agents. Next slide, please. Similarly, in a Cochrane review, the author has concluded that for women who undergo a cesarean section, carbetocin resulted in a statistically significant reduction in the need for therapeutic uterotonics compared to oxytocin. Also, carbetocin is associated with less blood loss compared to symptometrin in the prevention of PPH for women who have vaginal deliveries, and is associated with the significantly fewer adverse effects. Yes, come. What I realized in my practice is that of epigastric pain, nausea, vomiting in patients whom we use carbetocin, and there are less chances that we have to use any other drug when we are using carbetocin. Next slide, please. Next slide. So now coming on to the guidelines, WHO has included carbetocin in the guideline for PPH prophylaxis. Canada has also included SOGC, carbetocin 100 microgram IV bolus dose. Now, FIGO has already, carbetocin has been added as one of the recommendations for PPH management. And other countries have also included carbetocin in their guidelines for PPH prophylaxis. Coming on to the next slide, please. Can you change the slide for me?
Yeah, so thank you so much, ma'am, for describing all the efficacy and safety of carbetocin and its used in prevention of PPH. If you have to share your experience of using of carbetocin for prevention of PPH, its efficacy and safety observed in a particular case or in certain cases, what would it be, ma'am?
Basically, what I have seen is that when we use carbetocin, there are what in my clinical practice कि तुमको फिर और चीजें देने की जरूरत नहीं पड़ती, कार्बोप्रोस्ट है या फिर अर्गोमेट्रिन वगैरह देने की जरूरत नहीं पड़ती. एंड सेकेंड एडवांटेज इज जो एपिगैस्ट्रिक पेन और नोजिया जो पेशेंट को होता है when we use oxytocin, वो comparatively it is less. What I have realized over a period of almost 5-6 years, कि अगर हम 4-5 years जो भी मतलब कि initially जब carbetocin आया था तब तो no one wanted to use it, but when I started using it, what I have realized is that कि epigastric pain और nausea नहीं होता और साथ में तुम्हें दूसरा ड्रग नहीं यूज करना पड़ता.
Okay. Thank you, ma'am. So now we move forward to the next part of our session, that is panel discussion, where we'll be having certain frequently asked questions and real world scenarios. So moving to the first question, ma'am. Considering that the incidence of postpartum hemorrhage is more in India, what factors or reason do you think contribute to the more prevalence of or incidence of PPH in India?
Firstly, because in India, half of the population is anemic. Secondly, when we compare it to rural India, the problem is they don't first want to come to the hospital. Secondly, they will reach late when already the third stage of labor has already gone. So that is the main problem. That's why PPH and mismanagement of third stage of labor. वो भी एक reason है कि PPH is more in India, and poor socio-economic status.
Okay. Means we can also say that in rural parts the incidence is observed to be slightly more.
more, because they will not come to the hospital, and they are not they are mostly unbooked, unregistered patients, where they have
Okay.
not even shown to the doctor at least once.
Okay. Okay. Got it. Thank you, ma'am. Moving to the next question. So, ma'am, what are the patient profiles or categories of patient where we can say there is high chance of PPH?
Basically, the patients who are having placenta previa, the patients who are having twin pregnancy or triplets है, या फिर higher orders है, the patients who have conceived through IVF, yeah, the patients who are having some coagulation disorders like a liver disorder or any SLE, APLA syndrome, any patient who is having some kidney disorder associated with liver disorder. So such of the patients which are having some chronic diseases, they are more expected to land up in PPH, or Manibola jo IVF, twins, triplets. They are more the patients who are anemic,
Okay. Okay.
the patients who are having abruption. Uh, they are most common patients who land up in PPH.
Means we can also say that the prevalence or percentage of patient who have PPH because of anemia is also high in India, because the prevalence we can say of anemia is also on the higher side.
On a higher side.
Moving to the next question, ma'am. So it is related to anemia only. So you have spoken on this. Any additional comments if you would like to add? So is anemia considered a serious risk factor for PPH in India?
Yes, yes, definitely. Because when the patient is already anemic, already उसके पास hemoglobin is less. So if the hemoglobin falls, uh, अगर वो already 7 grams है, 8 grams है, so वो the patient will become clinically unstable at a very comparatively lower amount of blood loss. So even if the definition doesn't fit कि if the 500 ml नहीं हुआ vaginal delivery के बाद, then also if the patient is anemic, the patient will become vitally unstable fast. So in such patients, we have to be more vigilant so that we
Okay,
don't
okay,
lose the patient.
okay. Thank you, ma'am. So moving to the next question, ma'am, which are the drugs which are your drug of choice for prophylaxis of PPH and that you use regularly for prophylaxis of PPH?
Oxytocin, carbetocin, carboprost, and misoprostol. Most common we use this. Methergin we generally don't use in my setup.
Okay. Thank you, ma'am. So, moving to the next question. So, ma'am, do you use carbetocin for prophylaxis of PPH in all the patients or only in high risk patients? And what is the reason for it?
Only in high risk patients mostly, because low risk में तो we know कि a single dose of oxytocin or वैसे it will be enough, but specifically in high risk patients like the patients who are diabetic with a big baby, who are having placenta previa, who are having abruption, or the patients who are having IVF conception, who are twins, triplets, or who are having some chronic disorders, which can be a liver disorder. In those patients, we preferably use carbidocin.
Okay, ma'am. So, in those cases, ma'am, if carbetocin is not able to prevent PPH completely, is it observed that it reduces the intensity in those particular cases where PPH is still observed, but the intensity is reduced?
Yes, definitely. The uterine tone uh, lasts for a longer time, and there is mostly what I have realized कि हमें additional carbopros देने की जरूरत नहीं पड़ती. The second
Okay.
line.
Okay. Got it. So moving to the next question. So as considering the route of administration as IV route is the preferred one, if we modify the question a bit, are there any case scenarios or patient profile where IM route would be the preferable choice?
Actually, mostly IV route is preferable. I am generally, it is more painful, so better to go for an IV route, what I have realized. But
Okay.
अगर administration is a problem, ऐसा कुछ है कि अगर बहुत पेरीफेरी में डिलीवर हुआ है जहाँ आईवी लाइन लेने को किसी को आती नहीं है, देन यू गिव द पेशेंट एटलीस्ट आईएम एंड देन शिफ्ट द पेशेंट टू अ बिग हॉस्पिटल. सो तब तक इट विल बी फाइन, क्योंकि कई बार पेरिफेरी एकदम रूरल इंडिया की बात करें, एकदम वेरी इंटीरियर पार्ट्स ऑफ इंडिया वेयर दे डोंट इवन नो हाउ टू टेक अ लाइन, सो एटलीस्ट आईएम इज देयर अ प्रेफरेबल रूट, एटलीस्ट दे कैन गिव एन आईएम इंजेक्शन.
Okay. Means it depends on the area, we can say, what
It
facilities
depends.
they have.
Definitely on the area and definitely how much staff is trained.
Okay, okay, yes. Thank you, ma'am. So, moving to the next question, ma'am, how frequently do you see PPH even after using carbetocin?
It depends on case to case. If the patient is very high risk, then we know, okay, she will have PPH and we have to use something else. But generally, comparatively, it is lesser. But yes, definitely, there are some cases. It depends on case to case and patient to patient.
Okay,
हाँ,
okay,
because अगर PPROM की बात करें, very prolonged premature rupture of membranes is there. Then then the problem is that the patient is having sepsis, associated sepsis. Then obviously you will see more PPH in that, even after using carbetocin. Matlab, it depends on patient to patient, where you know
okay,
that patient is very, very high risk for PPH.
okay, okay. Thank you, ma'am. So, even if so, this question has been already discussed. We'll just move forward.
Yeah.
So, ma'am, what are the advantages, particularly of carbetocin over other uterotonics, if we see, for particularly prevention of PPH? And as you have already spoken on both the cities and peripheries, there is a difference. For example, if we say for oxytocin, any usage difference for carbetocin for metro cities and periphery? So, these two questions.
So basically, periphery में तुम्हें storage वाला problem will get solved, and we can give IM. So oxytocin also we can give IM, but carbetocin also we can give IM. So advantage है कि store भी नहीं करना पड़ेगा और IM दे सकते हैं, तो it is easy in the periphery. And what I have already discussed, that when we use one dose of carbetocin, तो हमें second dose अगर हमें कुछ और देना है साथ में oxytocin के साथ, अगर हमें carboprost देना है तो हमें carboprost देने की जरूरत कम पड़ती है. So carbetocin has an advantage कि एक ही vial में हो जाएगा mostly.
Okay, okay. Thank you, ma'am. So, you have already spoken on this, and considering the
Yeah. The
safety of.
side effects are epigastric pain, nausea, and vomiting. Definitely less with carbetocin. What I have realized.
Okay, okay. Means we can say that in majority of the patient, the safety is observed to be good.
Yeah, it is tolerated.
Okay, okay. So, moving to the second last question, ma'am. So, what is the benefit of using carbetocin as a first-line drug to prevent PPH in every patient and in every delivery? So, if we using it as a first-line drug in every case, for example, so what benefit would it offer?
Benefit I told you, na, we don't need to use any other drug extra. Chances of using other drugs are comparatively less. And
Okay,
secondly, the
yes, yes.
adverse effects of
So both efficacy
carbetocin.
and safety wise, it is observed to be a good, we can say yes. So moving to the last question, ma'am. So to our delegates, if you have to summarize your entire experience of using carbetocin, be it its efficacy, safety, your experience over the years, how would you summarize, ma'am? What would you tell to our participants?
I would like to tell that when you don't have any, कार्बेटोसिन इज स्लाइटली एक्सपेंसिव, बट अगर आप पूरी बात करोगे पूरी ट्रीटमेंट की कि हम एक कार्बोप्रॉस भी देना पड़े जिस पेशेंट को ऑक्सीटोसिन भी यू हैव टू गिव, तो वो कॉस्ट ऑफ थेरेपी इज ओवरऑल सेम. सो इफ you can use carbetocin, then you should use and you should go for it, so that वो जो दूसरा ड्रग है वो यूज नहीं करना पड़ेगा, तो ओवरऑल जो कॉस्ट ऑफ थेरेपी है वो इट विल बी सेम ओनली. ओवरऑल जो पड़ेगा वो, हाँ, जिसमें तुम्हें लगता है कि लो रिस्क प्रेगनेंसीज है एंड ऑक्सीटोसिन से हो जाएगा, देन द सिनेरियो इज कंप्लीटली डिफरेंट. बट व्हेन आई एम टॉकिंग अबाउट हाई रिस्क प्रेगनेंसीज, तो दैट इज स्लाइटली, इट हैज एन एडवांटेज.
Okay, okay. Thank you, ma'am. A very insightful point that you have shared. So now this brings us to our end of our session. So thank you so much, ma'am, for sharing your valuable insights and guiding all of us regarding efficacy and safety of carbetocin and sharing your experience as well. I would also like to thank all the delegates for their active participation and engagement into the meeting. So this marks the end of our meeting. Once again, thank you so much, ma'am, and we can close the meeting now.
Thank you. Okay.
Thank you, sir.